So grateful that the response was so large for today's presentation, and really speaks to the kind of the gravity of the discussion topic, how hot it is right now. And there's a lot of significant changes that are proposed in the CY26 OPPS proposed rule for hospital price transparency. And so what we aim to do today is really two things. One is we want to really provide some good education, orientation around the proposed changes that are included in the rule, and then also provide an opportunity for you to hear kind of some potential considerations for comment. We really believe that this is an important time for us as an industry to speak back and share with CMS some of our concerns with some of the things that have been proposed. I've spoken with my friends at AHA and HFMA, actually as recently as this week, as we kind of try to understand positions and how collectively as an industry we try to kind of voice back a unified response to CMS. And so just want to encourage everybody to keep an eye out for AHA and HFMA resources. They are finalizing some great resources for members as well, and those should be out in the days to come. So again, lots of activity that's happening right now. The commenting window will close on September 15th. And that's, again, why we wanted to make sure that that we provided this for you today so that you can get up to speed on what has been proposed, and also a platform to understand how to comment back to CMS. So I always think when we kind of do these discussions, it's really useful to think on the transparency timeline. There's a couple pieces that I think are really interesting on this particular slide. One is just some of the key things that have happened over the past several years, and then the other is just sort of the cadence of when these changes have occurred. So, we can go back to ACA for the original action for hospital price transparency. And it was just this one little sentence that was in ACA that, hospitals should make available a list of their standard charges. And from that one little sentence has, kind of carried out into a very robust reporting structure that we're working through today. And so FY19, the way that CMS sort of clarified that was, okay, it's got to be machine readable. It's got to be basically a list of your standard charges. A lot of folks basically to comply with that were essentially listing out kind of a description and then a price from their charge master, and that was it. CMS kind of looked at that information and said, hey, we've got to kind of further define that. And the definition for then standard charge exploded to 5 different types of standard charge. And the lightning rod of all of that, right, was those payer-specific negotiated charges. And a lot of what we're working through today is still how do we best display those payer-specific negotiated charges? So a lot of the stuff that we're going to cover today really goes back to that fundamental piece of payer-specific negotiated charges and what is the most appropriate way to kind of share those negotiated charges with the public. There was in CY22 kind of an increase in the monetary penalty component of this to make sure that hospitals were complying with the rule. And then probably the largest advance, I would say, was actually last July. Into effect went a standardized file schema, introducing also some new elements. Among those were the algorithm and estimated allowed amounts. And I kind of point those out because, again, what we'll get into today actually keys in on those particular pieces and data variables as well. So final note on this slide before we move forward, if you look at those kind of intervals between when some of these changes have taken place, it's really been about every couple of years that we've seen this. And to be honest, you could almost even say 4 years in between the CY20 and CY24 OPPS rules where there was very significant change in those periods. Fast forward to this year, and what do we see? It has really accelerated. 2025 has been a very significant year so far in terms of hospital price transparency action. It began in February with the presidential executive order that essentially called for action around hospital price transparency within 90 days. May came around and CMS proposed new guidance for kind of how to account for that executive order. There was also a RFI regarding how do we make sure that the MRF data is both accurate and complete. And those are also two very key statements that we're going to get into today as well. So kind of keep that in the back of your mind. This accuracy and completeness of the data are central into this. And then in July, of course, those RFIs were due. And we got what we're talking about today, the OPPS proposed rule. So lots of activity so far this year. And again, today's purpose is to make sure that we walk through each of these components and make sure that you've got good comfort around these 5 different areas that are a part of the proposed rule. Now, in most situations, right, these presentations, you try to almost leave the biggest thing to the end. And today we're going to do it a little bit differently. We're actually going to put the biggest thing at the beginning. I would like to share that if you get nothing else, I hope that you understand this very first portion, because I think it is the most significant change that is being proposed is in this strengthened attestation requirement. And so we'll begin there. Essentially what CMS is proposing is that beginning January of 2026, hospitals would include a revised attestation statement in their machine readable file that confirms that all that charge data is complete, accurate, and compliant with the CMS requirements. This includes 2 kind of critical things. One is there is a new mandate to name a senior official, a CEO or a president, that is going to be responsible for data integrity. The other piece that is actually a part of the attestation statement is that there is a recognition that if you are saying that your payment is built off of an algorithm, that you've encoded all necessary components so that the public could derive an actual dollar amount from the algorithm. And I want to sort of just pause and let that sink in. The statement is, you've got to provide everything that will go into your payer contracted rates and terms so that any individual could go in and be able to manipulate, work with the data that's in the machine readable file to arrive at what their dollar amount would be for them to have the service that they are planning to have at the hospital. This is a massive, massive statement. And let's kind of talk a little bit about this a bit more. So the actual language is right here. This would be the revised attestation statement. You may recall the one that's in there now is about a sentence or 2. It's pretty short. There's those key words that you're attesting that the information that's encoded is true, accurate, and complete as of the date in the file. And that there's this statement here that the hospital attests that the payer-specific negotiated charge based on a contractual algorithm, percentage or formula that precludes the provision of a dollar amount has provided all necessary information available to the hospital for the public to be able to derive the dollar amount, including but not limited to the specific fee schedule or components referenced in such percentage, algorithm, or formula. So what are we thinking about this? We think it's important to recognize what CMS has said is an algorithm. First and foremost, what are we talking about when they say, hey, if you're using an algorithm, then you got to tell us every part that's in that algorithm. So this is how they've defined it. Hospitals and payers establish the payer-specific negotiated charge by agreeing to an algorithm that will determine the dollar value of the allowed amount on a case-by-case basis after a predefined service package has been provided. This means that the standard charge that applies to the group of patients, in particular payers planned, can only prospectively be expressed as an algorithm because the resulting allowed amounts in dollars will be individualized on a case-by-case basis for a predefined service package and thus cannot be known in advance or displayed as a rate that applies to each member of the group. Now, we would contend this is a great definition. We would also contend that this is all hospital payment, we'll kind of go to the next slide here. Well, let me kind of flip one more ahead. If we think about kind of a typical patient experience, right? Like what happens, that patient's going to come in, they're going to receive care. That care then from a financial or payer-specific negotiated charge establishment is going to go to one of two or both branches of medical documentation, medical records and soft coding, and also hard coding charge entry. Hit our CDM, come into our billing system, go over to the contract management system, pull in all of the appropriate elements for how those terms and conditions are going to apply to that particular patient's unique experience. And from that allowed amount or that payer-specific negotiated charge will be billed. Again, coming back to this definition, we'd say, yes, that's a great definition. And that actually represents every single one of the cases that we have as a hospital. So what are the challenges then with this? Well, considerations for comment. One is the senior official, and this will kind of be the only sort of spot that we'll do this, and then we're going to deep dive into this algorithm piece. But you may, in fact, want to express some concern about naming a senior official on the machine readable file. We've heard from a number of folks that have that concern. We've obviously experienced some tragedy as an industry from a senior healthcare official that lost his life because of that information and his role being made public. This can be a very sensitive element, and so we understand the concern, and it may very well be that hospitals will want to convey a concern of listing a senior executive as the sole person essentially responsible for the accuracy and the completeness of this data. There's a lot that's there, obviously. The second really is deep diving into this algorithm requirement and the notion that all algorithm components can be supplied so that any patient prior to coming in would be able to understand how their negotiated charge would be billed. Again, we go back to that definition. If it's done in advance, right, like, and you're doing it on a case-by-case basis, how can we describe all of those potential areas? So the key point here is, how will we, from our hospital billing environment, account for all? If the statement is it's got to be accurate and complete, we have to describe everything that goes into this environment so that the public can create or derive a negotiated charge from that. So what type of logic are we talking about? Like, why is this a concern, and why do we think this is so burdensome? Think about the type of logic that will go into generating the payer-specific negotiated charge. We have payer-specific code categorizations and groupers. It's important to note that some of these payer groupers are actually proprietary. The hospital actually is not legally able to provide back or share the contents of that grouper. In fact, the hospital in some cases has to pay for a license for such grouper in order to be able to run claims through. But this would be suggesting that you would need to convey all of the elements that go into those payer-specific groupers and code categorizations. Those would all then have to be supported by corresponding lists of CPT codes, HCPCS codes, ranges of codes, revenue code ranges and values, procedure and diagnosis code ranges and values. All of that are examples of things that would have to somehow be fit into this model. You'd have to display not just what the DRG relative weights are, but also what platform versions are you using, right? Those exist in different ways. Or payers aren't always using the same or current MSDRG platform. We've got charge threshold logic for lesser of and stop loss provisions. That is all dependent on claim level service utilization that a patient would experience. We have surgical case grouping logic that's dependent on relative weights of thousands of soft-coded CPT codes and conditions, multiple procedure discounting rules that exist within corresponding lists of codes and conditions. We have all of our HIM and medical records policies and procedures that determine what those soft-coded assignments will be. We have packaging and exclusion logic that sometimes is payer-specific. It's also dependent on claim level criteria that's going to have corresponding codes and or code ranges. And then all of this then is going to be predicated on hierarchy rankings that say, based on this patient's experience, some of the payment terms may move up or down depending on what types of services they had and in which packages. So these are just honestly some of the bigger picture areas that you look at and go, how on earth would we get all of this information and conditional logic somehow in a single machine readable file that, by the way, is still structured in the way that it's structured today? So in essence, we'd have to fit this into a single cell. The other kind of problematic piece is, and where we've sort of maybe scratched our head a little bit, is we're having a difficult time understanding how this is connected, or rather disconnected, from other CMS hospital price transparency language. And we've pulled out a few of interest here. One, in the CY24 OPPS final rule, CMS actually went on record and said, in the interest of reducing burden and complexity of files, they would allow the hospital to provide a description of the algorithm rather than attempting to insert the specific algorithm itself in the MRF. We fully support the continuation of this definition because, again, we think it is exceptionally burdensome. And so, again, one of the comments that we want to provide back is, CMS, we agree with the previous communication that you've had on this point. From the current proposed rule, there are two elements too that are very interesting along these lines. For allowed amounts, they've actually had this statement that they believe dollar amounts are useful, especially given the complexities of hospital contractual arrangements with third-party payers. So if they're understanding that these are highly complex, how can we get highly complex, which again, we'd agree with, all of that highly complex detail into the single machine readable file? And the other one that's that I thought was interesting too is in describing the 10th and 90th percentile allowed amounts, which we'll get to in just a couple minutes. They've said requiring a hospital to post every possible value and the frequency of those values would be highly burdensome to hospitals and would produce unmanageably large data files that are difficult to access and interpret. And these are actually for statistical measures that can be calculated, let alone all of the thousands upon thousands of lists and conditions that go into building out our EMR. One kind of final note here on this. We've talked about how burdensome this would be, and I think we can all agree that the amount of administrative detail and time to go into an exercise to get everything out of again, our hospital billing environment and somehow into a single machine readable file is almost unfathomable. But here we think is the real kicker. Let's assume for the moment that it could be. You could somehow download everything that exists in your contract management system and EMR, all of the coding conditions and criteria, all of these things. You could somehow kind of put this into a machine readable file. What would happen next? Developers would need to actually build out a way to kind of ingest that data and build essentially a claim pricer so that they could then run claims through and understand what that payer's negotiated charge would be for a certain number of patients across kind of a distribution of patients. That value that they would arrive at is the allowed amount value that is already in the file. So what is a huge head scratcher to us is, why on earth would we attempt to download all of this information and then even have developers try to figure out ways to ingest and price out certain claims only to arrive at a value that is already contained in the file? So we really want to hit this point home to CMS that even if it was all there, and again, we can't conceive of a way for us to get it in there, but even if it did, the result would still be a value that's already in the file. So this is really, truly an unnecessary effort. One note here too, you could be hearing all of this and going, gosh, you know what? These algorithms, man, oh man, maybe an approach is I just go and try and almost like check a box and provide a simple DRG schedule or a fee schedule, a case rate value for some of this and just call it a day. And there are some that may have even previously felt that that was kind of what CMS wanted to see. You know, they put out these charge methods and said, there are 4 ways that hospitals are paid. They're paid via a per diem, a case rate, a percentage of charge, or a fee schedule. It's kind of the rules that went into that charge method variable. So there are folks that previously said, oh, okay, I'll maybe put a couple fee schedules out there or a DRG schedule, and that's it. Well, the challenge with that is, especially in light of this attestation statement, is while those values are probably based, right, in reality, they are coming from some schedule within the payer's payment terms, they aren't anywhere close to being a complete representation of what the negotiated charge would be. And so we really need to recognize those elements, and honestly, many more that go into a charge method or a charge methodology are only a part of the story. They are not close to being the full story. In fact, we've gone on record to say to CMS, our firm has literally modeled out thousands of payer contracts. We have yet to see an example, with the exception of an entirely POC-based contract, where one of those other elements, a per diem, a case rate, or a fee schedule, lives in isolation. There's always additional detail that goes into how a patient would be charged for something based on the hospital and payers' contracted rates and terms. Always. And again, it goes back to that slide of what are the conditions that flow into an algorithm, and they're immense, right? So, to kind of almost combat that thought that, well, maybe we go back in time, if you will, and try to just do something more simple, really, we don't see a way that a hospital could check that box and be simple or enter basic charge method data, because they can't attest to the completeness of that information. The other approach really is using that other algorithm and allowed amount. And that's the methodology that, again, CMS is trying to get some additional clarity around, because all of those algorithm components are encompassed. When we look at the claim, we know that everything that would have gone into paying that claim out, or pricing it out, if you will, was factored in based on that patient's utilization of services and the rates and conditions that exist for it. So with all of that, there are two final pieces here that we really want to emphasize in terms of considering what feedback to give to CMS. We plan to share that we believe CMS should maintain the current attestation statement without the requirement for hospitals to encode all algorithm components. It's going to be really almost involving an inconceivable amount of administrative burden. It's going to overwhelm the file and make it not machine readable or comparable. And again, even if all of it could somehow be conveyed in there, they're only going to get a result out that is the value that is already in the file. So it's really important, we think, for CMS to understand those two fundamental pieces. The other is we actually want to push to go one step further to say we believe that the payer-specific negotiated charge dollar amount field for fee schedules, case rates, and per diems, that this emphasis that's been placed on those really needs to go away, because CMS should acknowledge that those values are just simple components of broader algorithms, not standalone charges. When the public thinks that, oh, here is a DRG base rate and that's the end of story, or here is a fee schedule, that's the end of story, they're not factoring in, right, like all of the other conditions, all of the other ancillary services that can go into that typical patient encounter, and how that package, that service package, will be paid out based on those conditions and rates and terms. And so again, we're trying to actually not just say, hey, we don't want to do the algorithm components because it's burdensome and also, will not give us any other additional information outside of the allowed amount that's already in there, but really hammer on this point that, using the algorithm and using that allowed amount are truly the only way that a hospital can reasonably convey what the payer-specific negotiated charge for patient services would be. So lots there. Again, I know we spent the bulk of our time so far here. I promise time would even permit me spend this much time on the other remaining points, but this was one that we really wanted to make sure people have a really firm understanding of the gravity of what is being expressed here, and how, as an industry, we can try to convey these concerns to CMS. So the next is the replacement of estimated allowed amounts. You say, well, gosh, wait a second. We just talked about allowed amounts. So what's kind of going on here? It's not that CMS is saying that the estimated allowed amount is sort of off the charts. It's that they're sort of redefining it essentially. What was called estimated allowed amount will now be replaced with simply allowed amounts. And in three primary ways. One would be the median allowed amount. This kind of addresses sort of the average that was in there previously. The 10th percentile and 90th percentile allowed amounts. And then also, they are requesting that the hospital disclose the number of units, volume units that went into creating those statistical values. The other piece too that you'll see kind of on this slide is CMS has proposed really a non-standard calculation method for these percentile values. And that is when the median falls between two observed values, that the hospital use the next highest allowed amount rather than averaging the two. And obviously that's not standard statistical kind of logic. So let's think about this one in terms of what's being asked here. And it may be helpful to kind of just reorient on when that allowed amount is used. CMS, July of 2024, and the new schema introduced charge method, and then these different charge payer-specific negotiated charge values, and then also the estimated allowed amount. And what they basically said was, if you believe that your contract is a case rate, a fee schedule, or a per diem, you should encode those dollar amounts into the negotiated charge dollar amount field. If you do that, you don't need to worry about the estimated allowed amount. However, if you believe that your contract is represented as a percent of billed charges or other, which essentially is algorithm, you do need to provide the estimated allowed amount. And that estimated allowed amount was the average dollar amount that the hospital historically received from a third party for an item or service. So what are they saying now with this change? Essentially, the when and why, to use it, don't change. But what does change is that average, if you will, is now the median. Another one will be the 10th percentile, and another one will be the 90th percentile. So they're essentially clarifying what average really is, and they want average to be median. And then they're also asking for those two additional statistical measures to understand kind of what are more outlier components within that range of patient experience. And then again, the proposal would require the hospital to report the volume count used to derive the allowed amount percentile values. So again, the when for this is not changing, but the how, essentially, the how is. There's also something notable in the language in here where CMS shares that in situations where hospitals don't have historical claims data, so their examples were new facilities or a new or revised payer contract, they recognize there's not going to be any data available to calculate these fields. So in those situations, they propose that a hospital encode a 0 in the count of allowed amount. And then by nature of that, the median, 10th, and 90th percentiles would be blank. And then they just asked for kind of a note in the additional notes field that would say, hey, this is a new or recently revised payer contract. And they also recognized that it wouldn't preclude a hospital from updating it, if they wanted to, prior to their once annual kind of amount when the remittance did become available. So this was actually good to see on record that in the absence of claims data, that this was sort of how that should be approached. But their examples were kind of limited to a new or revised payer contract or a new facility potentially that's opening up. So with all of this in mind, where do we land? Kind of what do we think CMS should hear essentially from all of this? We first and foremost, we can be supportive of these new statistical measures. However, we do believe that CMS should just use standard percentile calculation methods, as opposed to if it's an odd data series, use the standard calculation method. But when it's an even data series, instead of averaging the two middle, use the next highest. A lot of statistical software packages that a hospital might use to construct the machine readable file, this would not be standard logic that would be built into those packages. So it would require a hospital to perform custom programming logic in order for these distributions to be accounted for. It could also skew results a bit. And so if we're thinking purely from a statistical standpoint, you then are representing the statistical measures in different ways given the data set. And so those two reasons probably mean that let's just not go down that custom route. The reason why they're doing it is that they want it to be based on a real value. But again, these values are real. They are based on real claims and real patient experiences. And so, we've tried to kind of convey that point as well. In the count, we have concerns that showing number of count less than 11 could violate or be a concern for HIPAA. And so we've just simply asked that an asterisk or a less than 11 symbol be provided in that cell so that a hospital isn't put at risk for providing a volume count for these situations where it's less than 11. And then the last point on here is, we support the methodology for handling kind of insufficient claims or situations where there's insufficient claims remittance to put values on the file. But some of you may recall back in May, one of the more confusing guidance elements in May was, hey, if you don't have historic reference points to calculate an allowed amount, still put an allowed amount on the file. And many of us reached out to say, we're not sure how that is technically feasible to create what is defined as a historic average when there is no historic data available. There has yet to be a response on that. We think this actually could be CMS's attempt to kind of share, hey, actually, this is what you could do, but we'd like for them to go on record and actually just say, in situations where a payer didn't have volume for a certain procedure and you can't calculate an allowed amount, then we follow the same methodology, or again, just exclude that service in the file, because it's just going to make it larger if you got a bunch of zeros in case categories where there is no volume there. Third one is standardization of data sources and methodology. CMS has said beginning January 1st, CMS proposes that hospitals be required to use EDI 835 electronic remits to calculate the allowed amounts. And this is important, that the look back period for the data would be limited to no longer than 12 months preceding the effective date in the machine readable file, and that $0 claims would be excluded to avoid skewed results. So considerations here, we think actually having the data source clarified is just fine. 835s is really probably where, again, we would be grabbing that information, right? It's the payment adjudication that's occurring. That is a good source for that value. The other piece, though, that we think is important for CMS to hear is, they want a year's worth of data. That doesn't seem unreasonable. But what is a good clarifying point is, if they're taking that 1 year of data from the machine readable file date, hospitals have two things kind of potentially working against them in grabbing a good data, representative data sample from that. Is, they may be working on that file months before the effective date. And the other is, sometimes claims aren't adjudicated, right? in a extremely timely manner. And so they might not have access to some of those claims either. So what we've recommended is that look back period be extended to 18 or 24 months, so that hospitals feel like they can go back, pull a representative data sample that really provides enough data to be meaningful for patients as well. So we hope that will be a reasonable adjustment to that provision. The other consideration that we're planning to kind of pitch to CMS is, once we have this data and they're saying, the claims data is the authoritative source, if you will, for these allowed amounts, which is great to have kind of what the defined source would be. But we still will run into a situation of how those claims will be grouped in terms of reporting. And there are only the right side of your screen, these are the only valid values for code type. And so what we've said is, why not just, if we want to sort of make this consistent, let's group these by MSDRG on the inpatient side, and then let's use a primary APC based on a highest weighted HCPCS code on the claim for the outpatient side. So there's a claim identifier essentially for outpatient visits as well. This would allow everything to be able to be reported consistently. We could now have comparability across hospitals and plans, reduce variation, and then kind of align also to CMS payment methodologies. So, again, for whatever it's worth, this may not be as important or critical for you at your hospital, but we really feel like we're probably going to keep kicking around comparability of data. CMS, right, wants this data to be leveraged and the ability to sort of compare it across. And really, until we agree on a common methodology to group claims, we're going to keep circling around on, gosh, the data isn't, it's not apples to apples. So we've proposed back what we think is a fairly simple methodology to do that. CMS is also asking for the type 2 MPIs to be listed out in the file. So those beginning with 28, which indicates hospital, or 27, indicating hospital unit, to be in the machine readable file. That'll go into a new data variable. Primary reason here is they want it to be more comparable, or to be able to be aligned with the transparency and coverage payer files. We don't see a massive issue with this. The one thing that we actually think could be a comment back to them, however, is right now, you're probably all aware, right, that in the naming convention leverages the EIN on the file. That's created a lot of confusion for hospitals, and also in some cases a lot of sensitivity to having kind of that number that's not necessarily floating around in the public domain, now floating around in the public domain. And so one of the things that we've asked CMS to consider is dropping that on the file naming convention and just using the Medicare provider number as a reference point instead. So we think that there could be a lot of utility to that, and also help maybe clarify. Sometimes we get the question from hospitals of, when do I report out a separate file? And some of that can be a nuanced conversation, but if essentially a file is produced when you have a Medicare provider number, it just makes it a little bit more clear cut. So, those are things that we think would be helpful for CMS to hear as well. And last on this list is civil monetary penalties. I guess the biggest one was the one at the beginning, but probably the one that maybe caught your attention was the one at the end. So there really isn't anything super shocking or problematic here, honestly. CMS is not adjusting the when and how of when the civil monetary penalties would be imposed. So that would remain intact and would be imposed when a hospital fails to respond to a CMS warning notice, or they fail to comply with the corrective action plan. The only substantive change is that CMS proposes this optional 35% penalty reduction if a hospital waives its right to an administrative hearing and accepts responsibility for the violation. So there have been about, I think there's currently 27 civil monetary penalties that have been imposed by CMS. And one of the things that I think they're hopeful for with this change is that instead of going through an appeal, which I think maybe 20 of those 27 are trying to work through an appeals process, that the hospital just says, you know what, instead of trying to appeal this and maybe fight for some reduction, and CMS, wants to do the same, the hospital can just say, you know what, we'll admit we were at fault, and in doing so, we'll add our machine readable file or add our consumer shoppable file back up in a compliant way. Um, so we'll accept the responsibility. We don't want to go through the hearing anymore, but you'll get a 35% reduction in penalty to kind of, not go through the process of the appeals. So again, it's not really, I think, a super problematic area. It doesn't impact really too many folks. And, we've just simply said we think it could probably strike a fair balance, if and when a hospital believes that they were at fault and did not do the things that they were supposed to do in the time periods that they were supposed to, and wanted to kind of have a more speedy process that is also less costly. One final consideration in all of this is time. As we were going through, you probably noticed one common statement in each category, and that is beginning January 1st, 2026. And so one thing we really want to try to convey to CMS is that timing is really, really problematic for any changes, even simple ones potentially, that they might modify. And really, it's just thinking through the timeline ahead. The reality is that final rule really probably won't come out typically until November. So by that point, many hospitals have either already produced their files for January 1st, or they are in production at that point. So to understand what the new changes would be, to reconstruct the file, to test that file and have it live literally weeks after is really, again, even on a small change, is very, very difficult. And again, could require a hospital to go back and have to redo a file completely because it was already done and ready to go. So the last piece too is we're kind of pitching more for a January 1st of 2027 for any changes, because you may recall, right? We dealt with this a year ago. Hospitals that were not on a July 1st cadence, well, that required them to produce two files in 1 year, the one that they had live on January 1st, and then an update on July 1st to account for all of the schema changes. And again, that really kind of unfairly burdens a group of hospitals as opposed to just saying, hey, you know what, here are any proposed changes, let's modify and have these a part of the file schema that would go live the following year. So with that, those are really kind of the summarizations of the key components of the hospital price transparency areas within the proposed rule. We do have at the end of the slide deck here just some reference points for you, a link to kind of how to access just the detailed language that's in the Federal Register. Sometimes that can be a little bit challenging to find, so that is in there. The kind of comment that we have out on our website as well. So aside from the slide deck, which is going to have a lot of summarized content, we have more kind of text-based written commentary, so that if you wanted to potentially, use some of those comments within the construction of your own comments back to CMS, we want to make sure that that's available to you. And then along those lines, there's also kind of some information here on how to go ahead and reply back to CMS with your comments. That deadline, again, is September 15th. and there are 3 primary ways that hospitals can submit information back electronically, by regular mail, or express, or overnight mail. I mean, typically the electronic way is the easiest to get it into CMS. I've done a lot of talking. I can see it looks like that maybe some questions have come in, and so let me try
Jamie,
and.
You might want to check the chat. We do have a few questions. I'll answer. One of them is regarding the slides, and yes, they will be made available after this. We can email those out. And I see that there are a few other questions. If you don't see them, Jamie, let me know, and I can kind of help direct them.
Awesome. Yeah, cool. Thank you. Yeah, and I do. I can see them now, Mike. Thanks. Yeah,
Okay.
some good ones out here. So, yeah, let's try and work through some of these. So, I like the first one. Payer published price transparency data has been shown to be incomplete and inaccurate. Why has CMS chosen to establish inconsistent processes for payers versus providers? It's an excellent commentary point. I will say I think they are getting that message more. There are some hopefully changes that they are proposing and trying to enact that will make the payer data more accessible and hopefully more accurate. But yeah, I mean, we completely agree. I think it's a fantastic point. Does the absence of historical data apply to new services as well as new facilities or payers? Yeah, it would. I mean, the piece that's specifically called out in the proposed rule is really on new facilities or payers. I think CMS would lump in there a new service altogether. But the clarifying piece that we'd like to see is for an existing service that just wasn't utilized by by an existing payer. You know, the May 22nd guidance it alluded to the fact that there should somehow be an allowed amount value, which again is defined as historical average, when historical data doesn't exist. And so, you know, again, many of us were like, we don't even know how somebody would do that. And so we asked for further clarification, and we've not received that yet. Again, I'm trying to read between the lines here and think maybe this is an attempt at that, but it's a good opportunity thing, I think, for us to go on record to say, hey, would this other, other kind of piece also apply here in those situations? So great question. As a reminder, that's right. So we've got Q&A. Will the calculated ratios be an adherence that the payers will be subjected to for their own patients? Yeah, right now, this is great. Yeah, I mean, right now, these provisions are specific to the hospital price transparency files. I will say there have been several points, though, within RFIs that CMS has put out for how to bring greater alignment between the payer files and the hospital files. One of the things that we believe could be leveraged is if we just focus on allowed amount reporting methodology and we agree on the data source and how to group those, we can then bring alignment between the two files. But that's the stuff that we've got to be able to kind of account for. And right now it's not aligned. So that's one of the reasons why, even though they weren't specifically asking for it in the proposed rule, we've gone ahead and inserted language that we had back in our July, just last month, RFI response to try to kind of, again, re-support this conversation topic. It's a really good point too, good call out.
And Jamie, if you can switch over to the Q&A panel, it looks like there's at least one more question there that might.
Perfect. Yes, I see it. Great. Okay, yes. In instances where there is logic applied to fee schedules, check here first, then here, etc., do all the schedules need to be provided, or can a final schedule be used. The reason there are multiple schedules is because the payer puts all codes on every schedule, leading to overlap with $0 reimbursement. Yeah, this is excellent, and I think is really one of the many, many, many questions that would come if this language here gets introduced. If that attestation statement goes into effect, it wouldn't be just those different fee schedule methodologies. You really are then trying to explain all of these other methods, values, hierarchies, rankings, all of that in the machine readable file. So your point is a great one, and actually, is really one of probably a million different questions, right, that we would have as we would try to convey all of the logic in our contract management system and in EMR into the single machine readable file. Again, to me, this is the major point that as an industry we have to be able to convey back to CMS that, one, ultimately all hospital payment is an algorithm. The patient comes in based on its utilization, that patient's utilization of services. We bump that up against all of the rates, terms, conditions that exist within the payer kind of algorithm logic, and out comes the payer specific negotiated charge through that allowed amount variable. With that, to explain or to convey all of that, it is really, again, just unfathomable, and very likely, right? Like, is not legal because some of those methodologies the payer actually has, or a third party vendor has the proprietary methodology. Interesting enough, right? Like Medicare, if it's based on Medicare, you'd also then have to describe all of the Medicare logic, which is kind of in a sick way, kind of a humorous thing to think about, right? Like trying to convey that back to CMS. So all of the nuances there. So there's just a mountain of questions that would result in this, and potential legal action too that would result if, because again, I'm not sure how a hospital would technically comply or legally comply with this when it would not actually have copyright or proprietary rights to be able to disseminate or to display the logic that underlies some of those groupers or custom systems. All right, we have gone just up to the hour. We can't thank you enough for participating today. I hope this has been helpful. I hope it's given some information, some thoughts to kind of consider in commenting back. Again, we just highly encourage you to think about this and provide CMS comment back, because some of obviously this, if it's implemented, gets to be fairly daunting and scary stuff. Ken, thank you so much. If you do have follow-up questions, we are happy to have kind of follow-up conversations with you. But as Mike mentioned, we'll have these resources made available on our website, and just look forward to continue the conversation in days, weeks to come.